I'm Mark Furth. I'm the scientific director of the Fibrolamellar Cancer Foundation, and I'm here to introduce Dr. Allison O'Neill from the Dana-Farber Cancer Institute and Boston Children's Hospital as part of a new series that the Fibrolamellar Cancer Foundation is hosting on the web to help connect the fibrolamellar cancer community with physicians and researchers who work on fibrolamellar carcinoma. We'd like to thank the Chan Zuckerberg Initiative for the funding that's enabling this series. So let me introduce again Dr. O'Neill and ask her to tell you a little bit more about herself and her involvement with fibrolamellar cancer.
Hi, Mark. Thanks so much. It's an absolute pleasure to be here. As many of you know, I'm a physician and pediatric oncologist at Dana-Farber Cancer Institute and Boston Children's Hospital in Boston, Massachusetts. There, my primary role is clinical director of the Pediatric Solid Tumor Program, and likewise the director of the Liver Tumor Center of Excellence. This means I devote all of my time to the care of solid tumor patients, both clinically and research-devoted efforts, and have a specific passion for caring for pediatric patients with liver tumors. Over the last many years, as we've grown our Liver Tumor Center of Excellence, we've cared for more and more patients, both with hepatoblastoma, the most common liver tumor, but more notably hepatocellular carcinoma, a more rare but certainly equally as important tumor that can affect pediatric patients. It's through those efforts that I initially started working with Mark and others at the Fibrolamellar Cancer Foundation, particularly centered around my passion for caring for patients with this disease, but also the difficulties in caring for these patients. So it's a pleasure to be here.
Dr. O'Neill, we're going to focus in this discussion on liver cancers that affect the adolescent and young adult community primarily. As you said, hepatocellular carcinoma and fibrolamellar carcinoma. Could you give a little bit of a sense of what is similar and different between these two forms of liver cancer, and particularly as they affect that particular age group in the so-called AYA population?
Absolutely. And I think what you're highlighting is so important, that hepatocellular carcinomas tend to affect the older age group in pediatrics. And so when we think about the AYA population, we think about approximately 12 to 13 years of age, all the way up through 18 to 20 years of age. And we as pediatricians do care for that latter portion of the population that is bridging to adulthood. Hepatocellular carcinomas in this patient population, as I mentioned, are rare. We think there are probably about 80 to 100 diagnoses per year in the US of hepatocellular carcinomas, but that doesn't differentiate between what we deem to be conventional versus fibrolamellar carcinoma. And the two are extraordinarily different. And I don't think we yet know the absolute incidence of one versus the other. And I think that varies significantly depending on individuals' practice and what they see. We do know that conventional hepatocellular carcinoma in pediatrics is very different from what affects adults. In adults, that disease tends to occur in patients with cirrhotic liver disease or other liver abnormalities, where in pediatric patients, the converse is true. Interestingly, fibrolamellar carcinoma tends to unite the pediatric population very closely with the young adult population, in the sense that the tumors seem to behave more uniformly across the population. We know genomically they're similar, and yet I think we still have a lot to learn about whether the AYA population differs and what heterogeneity really exists in the fibrolamellar carcinoma patients.
Thanks, Dr. O'Neill. Perhaps you could also give us a little bit more of a sense of how this liver cancer is treated today, and particularly for fibrolamellar, but also, I guess, the young adults with hepatocellular as well. And what are the distinctions between treatment for the different categories of liver cancer in your practice?
It's a very challenging question. And I think the challenge is that there hasn't been a great or established standard in how to treat these patients. When we think about conventional hepatocellular carcinoma, we really subdivide that and put those patients aside, because we believe that fibrolamellar carcinoma is really a completely different entity. And yet, independent of these two groups, we still face enormous struggles. These diseases are unbelievably difficult to treat and even harder to cure, particularly for patients with advanced disease. Historically, we in pediatrics treated hepatocellular carcinoma very similar to the way we treated hepatoblastoma. In truth, many of these patients were grouped together in the same clinical trials. And so what we know about treating hepatocellular carcinoma in children, we learned from how we treated hepatoblastoma, i.e. with standard chemotherapeutic regimens. And so we know, interestingly, that for a cohort of pediatric patients, they respond quite nicely to chemotherapy regimens. What we've also learned is that there is enormous heterogeneity in this patient population. Some patients will respond to chemotherapy, others won't. Some will respond beautifully to targeted agents, others won't. And we're entering into the realm of immunotherapies, which are so unbelievably promising across diseases in adults. But again, we see great heterogeneity in how patients respond. So there's really no perfect one-size-fits-all. And we as a community have had to come together and really unite to think about these patients clinically and to focus our research efforts about learning more.
So Dr. O'Neill, you've talked about really the three different categories of liver cancer in pediatrics: the hepatoblastomas, which affect very young children, and then the hepatocellular carcinomas and fibrolamellar that affect adolescents and moving up into, in the case of fibrolamellar patients, up to maybe about age 40 at time of diagnosis. For the fibrolamellars, it's understood in the community that there's no standard of care, as you've explained, for some of the complexities. Could you tell us a little more about what's meant by standard of care and what we're going to be trying to achieve in the future in this disease?
Absolutely. When we think about standard of care, that is treatment that is adopted from historical trials. So for instance, if a trial was run over the course of a decade for a particular disease, and agents were proven in that trial, agents, by agents I mean either chemotherapeutics, targeted drugs, et cetera, if they were proven to have worked upon study of enough patients, those agents are then adopted as what we call quote unquote standard of care, i.e. we have the data, we've researched patients and the care of these patients thoroughly, and we know the drugs work. The challenge with fibrolamellar is A, it's so rare. B, up until only recently, we didn't really know how to molecularly characterize the disease. So the reality is we probably have underdiagnosed patients over the years, i.e. we haven't had the tools to definitively count or account for the majority of patients with this disease. And we haven't had the opportunity prior to the Fibrolamellar Cancer Foundation and the Chan Zuckerberg Initiative to bring together a host of talented individuals thinking about this rare disease and to move in the direction of studying it in a uniform way. So because we've never had an opportunity to study such a rare entity together, prospectively, i.e. collecting data in real time and over time as we treat patients in a uniform way, we haven't been able to establish a standard. And without a standard, how can you conclusively say that a treatment is or is not the best available therapy for a patient? So that's the complexity of where things stand now and what we hope to change going forward.
Thanks, Dr. O'Neill. So you've given us a really good picture of what people sometimes refer to as evidence-based medicine. And perhaps you could talk a little more about what clinical trials are and how they fit into that notion.
I'm happy to. I'm a firm believer in evidence-based medicine. As a pediatric oncologist, everything we do centers around evidence. Again, we're good at studying rare diseases. Thankfully, cancer in pediatrics is rare, but that also means the only thing we know about pediatric cancer is what we know from working together in consortia, collaborating, accruing as much patient data as possible from which to draw substantive conclusions, i.e. evidence-based decisions. And so the way we accumulate this data is, as I mentioned, studying patients in a uniform and prospective manner. And often the only way to do that is to collaborate amongst institutions to come to a consensus regarding proposition of therapy. And some of that is difficult, right? When you have limited data to go on, what do you propose for therapy? And I think that's why bringing together so many smart minds and accumulating data that we each have will allow us to best move forward with the next most promising therapy. And so what we do is we create what's called a clinical trial. We design the trial in a very thoughtful way to accrue patient data and participation, and to follow these patients from start to finish. And not only start to finish as it pertains to the drug they're receiving, but what we call correlative data. So laboratory work, how well they tolerated the treatment, toxicities associated with the treatment, and then on a very granular level, scientifically, what's happening to the tumor as they get treated. Data like that is so important. And so clinical trials allow us in a uniform and consistent manner to think as a group of smart minds and to follow patients longitudinally. And only with that kind of approach can we conclude what is or is not helpful and then move on to the next thing if what we've chosen up front wasn't the right approach.
Thanks for that introduction to what a clinical trial is all about and why they're important. We're going to talk about two different clinical trials with you and really maybe compare and contrast what these kinds of trials are. You've talked a lot about the importance of cooperation among different institutions and oncologists in looking at potential therapies for patients. Perhaps you could tell us about the Children's Oncology Group and how that group facilitates that kind of cooperation.
The Children's Oncology Group is the largest consortia devoted to the care of pediatric oncology patients in the United States. It's comprised of multiple individual institutions, all united towards a common goal. And these institutions are in every single state throughout the US. It's the only way, as I mentioned, we in pediatrics can study these rare diseases. The Children's Oncology Group goal is to create a prospective clinical trial for each individual disease. And so by that, I mean for patients affected by brain tumors, there are multiple brain tumor clinical trials. For patients affected by bone tumors, there's a bone tumor committee and clinical trial. And for patients with liver tumors, we likewise have a liver tumor committee. And so each time we create a clinical trial, we accrue patients for up to a decade, and then we generate the data from the prior trial. We determine what worked best, i.e. what becomes the new standard of care, and we build on that. We ask new questions. We try to minimize toxicity and improve outcomes for patients with difficult to treat disease. The most recent clinical trial was probably the greatest feat yet in the sense that it was intended to be an international trial to not only include all of the sites throughout the US, but our collaborators throughout all of Europe and Japan. And from that was born what we call the FIT trial. That's the Pediatric Hepatic Malignancy International Therapeutic Trial. And as I mentioned, this was an opportunity to combine multiple institutes throughout the United States, all throughout Europe and Japan. The primary PI of the study is Greg Tiao out of Cincinnati Children's. And as I mentioned, multiple PIs at individual institutions are helping to run and open this protocol. For many years, the Liver Tumor Committee was focused solely on hepatoblastoma, as I mentioned, the most common disease affecting the liver in pediatric patients. But that's very young patients that are affected by that disease, and hepatocellular carcinoma didn't have a home. And so for the first time, myself and Dr. Arun Rangaswamy out of UCSF decided that it was time to incorporate hepatocellular carcinoma into prospective clinical trials through COG. And through the work of multiple individuals, we were granted the opportunity to write a hepatocellular carcinoma arm to this trial. And in our minds, this was an enormous opportunity to not only better understand the complexities of the care of these patients, the epidemiology across the United States, and to identify the true incidence of hepatocellular carcinoma, conventional and, most importantly, fibrolamellar, but also to propose a uniform treatment for these patients prospectively. There are many challenges, as you can imagine. Because we were conducting the study in the United States, Europe, and Japan, we had to choose agents or drugs that we knew could be easily accessible across all nations. And because historically we treated these patients like we did hepatoblastoma, we had a lot of data to suggest that chemotherapeutic drugs were efficacious for some patients. So due to these limitations and our desire to really accrue patients, study how they do with receipt of chemotherapy, and better understand the biology of disease, we wrote the clinical trial to account for two patient populations, those with upfront resected disease and those with advanced disease. And we proposed different therapies in those two arms with the ultimate goal to accrue as many patients as possible and better understand and learn from the treatment of these patients in a uniform manner.
Dr. O'Neill, is fibrolamellar carcinoma part of that so-called FIT or Pediatric Hepatic Malignancy Therapeutic Trial?
It is, in fact. And I think that's been debated because folks worry that fibrolamellar carcinoma patients don't respond to chemotherapy. In truth, before writing the trial, we accumulated as much data as possible, not only from collaborators in the US, but also abroad, with regards to their use of particular chemotherapeutic agents and the frequency with which they saw response. And they did document up to a 20-30% response rate for many patients, fibrolamellar included. And so that was really our impetus in suggesting more rigorous study of chemotherapy in these fibrolamellar patients to determine whether we could verify that incidence of response and determine whether it was worth studying more chemotherapy in the future. The reality is the most important principle is getting a patient to a point of resectability. And the best question that still remains is how to get them there, whether it's through standard conventional chemotherapeutic agents, targeted agents, or immunotherapy. And without study, we'll never know the answer.
When you say resectability, Dr. O'Neill, could you tell us what that implies?
Of course. We know that the two most, one could argue the most important principle for the treatment of fibrolamellar patients is the ability to resect or remove all disease surgically, all imageable disease. So the challenge there is our imaging studies are only as good as our technology. So we believe that what we see is all that's there. And I think the reality is there's probably microscopic circulating disease always present that we can't image. So while surgery is of utmost importance, systemic therapy or therapy delivered to the rest of the body is equally as important because we have to treat what we quote unquote can't see. But without surgery, we know we can't cure patients. So if we can remove all disease up front, wonderful. That would be the pie in the sky. But what we really need to do is better study agents that can shrink disease or facilitate an easier surgery. The two have to be thought about in conjunction.
So that's a great introduction to the kind of teamwork that's required in treating cancer, and why patients might think about enrolling in this particular clinical trial. Could you tell us a little bit more about how patients and families can get information about the FIT trial and who's eligible to enroll?
Absolutely. Any institution affiliated with the Children's Oncology Group, which is the vast majority that treats patients, pediatric patients with cancer, will have access to and information about this trial. And so I would strongly suggest that patients and families look at all available options and ask their providers specifically about this clinical trial. The eligibility criterion is fairly broad. Any patient less than 30 years of age. And as I mentioned, patients both with resectable disease at diagnosis as well as advanced disease are eligible. There are, of course, criterion regarding laboratory eligibility and things of that nature, but we tried to keep the trial as broad as possible to not only encourage, but allow as many patients as possible to be eligible for enrollment.
Another place where one can get information about clinical trials is a website hosted by the National Institutes of Health, clinicaltrials.gov. How would somebody go about finding this trial in the clinicaltrials.gov resource?
Absolutely. I know that that you and others have worked very hard to highlight fibrolamellar carcinoma in particular, enabling individuals to go on clinicaltrials.gov and search by disease category. And so I know that that's often been a challenge in the past for patients with fibrolamellar disease. They couldn't always put in fibrolamellar and find a clinical trial that was applicable. And I know there are a lot of efforts underway. So simply going to clinicaltrials.gov and searching for that term can very ably provide a list of available clinical trial options. Certainly searching under the broader umbrella of carcinoma can yield additional options perhaps, but our goal is really to provide more information to the families of fibrolamellar patients in an easier format.
Dr. O'Neill, in looking at some of the details of the trial that you've been describing, it's primarily a trial of different combinations of chemotherapeutic drugs and at least one targeted drug for hepatocellular carcinoma. Could you tell us a little bit about the rationale for using combinations and what is the study really aiming to learn about different combinations of drugs?
Absolutely. So in order to talk about that, I'll talk a little bit about the historical reference point for this. I had mentioned that pediatric hepatocellular patients were previously treated much like hepatoblastomal patients. And so we have a decent amount of data regarding the chemotherapeutics alone. Interestingly, our German colleagues combined chemotherapy in a very small study with a drug called sorafenib. That's a tyrosine kinase inhibitor that has been very well studied in the adult hepatocellular cancer population as a single agent. And so interestingly, our German colleagues said, well, children are strong. Let's see if they can tolerate that combination. And the reality is children are quite resilient in terms of the combinations of drugs they can and can tolerate. And so their study of the combination of both chemotherapy plus sorafenib showed higher levels of response and perhaps promise towards moving a patient to resectability. However, that was very small patient numbers. So our goal was really to validate that data on a larger scale, to better understand the signal that our German colleagues saw and determine whether this was worth pursuing going forward. So the clinical trial as it currently stands for patients with resectable disease up front, we first seek to determine whether they have a normal underlying liver. If the patients have an abnormal liver or predisposition to hepatocellular carcinoma, they go into their own category. But patients without a predisposition, i.e. conventional hepatocellular carcinoma that occurred on its own, or fibrolamellar carcinoma that have upfront resectable disease, our goal is to give 4 cycles of chemotherapy plus this targeted agent to determine whether rates of recurrence are low and to reduce rates of recurrence. Again, the combination has been proven tolerable in the past, and our goal is to study it more prospectively going forward. For patients with advanced disease, as I mentioned, these are the patients that are harder to cure because it's much more difficult to surgically remove all sites of disease if they have disease spread throughout their body at the time of diagnosis. What we know from limited data, as I mentioned, from our German colleagues, is that the combination of sorafenib plus chemotherapy was fairly efficacious, but it didn't get all patients to a surgically resectable state. So our goal for these patients, which we understand to be quite sick at diagnosis at times and with quite extensive disease, was to try and give chemotherapy in a more compressed fashion. So the trial arm for these patients actually randomizes patients to the German regimen versus what we call an accelerated or compressed regimen that not only introduces additional chemotherapeutic agents, but gives them in a tight time frame. We think that's important because the disease can grow fast, and there's a lot of heterogeneity, as I mentioned, between patients. So the goal is to try and deliver as much therapy as we can in a shortened time interval to get patients to the surgical resection they so very need on a short timeline.
Thank you very much for that explanation. I just wanted to ask a general question, which is, are there other aspects of this trial that you'd like to tell people about? And again, why patients would, specifically with fibrolamellar carcinoma, consider enrolling in it?
I think this trial has been an enormous effort of a lot of brilliant minds. I think it's been an absolute pleasure to be a part of. I also think that the individuals engaged in learning more about the biology and better understanding what makes these tumors tick are so dedicated to studying these tumors. And so for fibrolamellar patients that haven't yet had a home, that haven't yet had the opportunity to be treated in a conventional or uniform way with the hope of enhancing or improving outcomes, and with the promise on the back end of perhaps learning more about these tumors that can really substantially influence where we go from here. You know, we need to kind of come together in a scientifically rigorous manner to best understand where to go from here. And my hope is that this trial, as a very stepping stone, may allow just that and allow even more enhanced and focused effort, not only in the US, but in Europe, throughout Japan, of all of our colleagues engaged in this effort.
Dr. O'Neill, you've talked about hepatocellular carcinoma, hepatoblastoma, and fibrolamellar carcinoma being distinct entities. For fibrolamellar patients in that AYA category, it would be helpful to really go through the differences between hepatocellular carcinoma and fibrolamellar carcinoma.
Sure. We fundamentally believe them to be very different on the basis of a few things. First off, we know that conventional hepatocellular carcinoma and fibrolamellar carcinoma look completely different under the microscope. Conventional hepatocellular carcinoma in adults can include aspects of cirrhosis. In pediatrics, occasionally cirrhosis, but really just angry, more aggressive looking, larger liver cells. Whereas fibrolamellar samples under the microscope have a very distinct, what we call histology or appearance. The tumor is characterized by bands of fibrous tissue interspersed with sheets of abnormal looking liver cells, i.e. the fibrolamellar aspect. That's where the name is derived, these sheets of cells with the interspersed fibrous bands. So right off the bat, we know they look very different. Secondary to that, about 2/3 of conventional hepatocellular carcinoma tumors secrete what's called alpha-fetoprotein. That's a tumor marker that circulates throughout the bloodstream. Fibrolamellar carcinomas don't really secrete this tumor marker to any appreciable level. There are some records that perhaps some patients have a minor elevation, but the reality is the degree of elevation in conventional HCC versus fibrolamellar is really quite different. So we don't traditionally categorize fibrolamellar tumors as having an elevated AFP. The third piece is clinically, patients can have a very large range of clinical course. So for instance, some patients with fibrolamellar have a more rapid disease course in terms of disease growth, but the majority have more indolent growth. And that too tends to be in stark contrast to conventional hepatocellular carcinoma. And finally, you had alluded to the molecular differences. Fibrolamellar carcinoma, as we only know in the last few years, is characterized by a chimeric fusion. That's a genetic abnormality that is found only in these tumors. Conventional HCC tumors don't have this genetic abnormality. And so it's just another confirming piece of data that suggests that the origins of this tumor are different, that the histology, the behavior, the clinical course are different, and that this is a completely different disease entity that requires its own, not only school of thought, but dedication towards research and clinical care.
There's been tremendous excitement in the oncology and patient community over the past few years about increasing introduction of therapies that are activating the patient's own immune system against a cancer, or immunotherapies. Could you tell us a little bit more about immunotherapy for the kinds of cancers that you treat?
Absolutely. Immunotherapy is, mind-boggling in my opinion. I never thought, in my lifetime, we would see such unbelievable advances in what we perceive to be a completely new field. This was a field that didn't even exist years ago. And there have been such exceptional advances in use of immunotherapy for the treatment of many adult solid tumors. And so naturally, as you see responses in some diseases, the next best goal is to apply immunotherapy to the next disease and see if you can stimulate a response there as well. So there is already adult data in conventional hepatocellular carcinoma in particular, suggesting that use of immune therapy is promising. I think the challenge with fibrolamellar, as we've already mentioned, is that the disease is rare. We don't know whether it's been adequately or molecularly characterized in the past, although we think now that the vast majority of institutes are capable of looking for the genetic aberration and adequately identifying these cases. But we have a lot to learn as it pertains to the immune environment of these tumors. I keep going back to the patient heterogeneity because I do think every patient's tumor is a bit different. But certainly from what we've seen on a preliminary basis is that these tumors do harbor an immune infiltrate. And by that, I mean there are human immune cells from the patient embedded within the tumors. And that's important because immunotherapy capitalizes specifically on that topic. The fact that there are immune cells embedded within the tumor that you can potentially take advantage of and or reactivate. And so the whole premise of immune therapy is to capitalize on immune cells embedded within a tumor and hopefully reactivate them in a meaningful way such that those immune cells, which previously didn't recognize the tumor, can recognize the tumor and fight it. I think for fibrolamellar carcinoma, we have a lot to learn, but there's enough promise to suggest that immune cells are present and that they might be an excellent tool to direct our efforts on subsequently as a mode of therapy.
You've talked about the importance of getting objective data about how cancers respond to particular treatments. What are you doing to get that kind of data with immune therapy in fibrolamellar carcinoma and other liver cancers?
Thank you for asking. I have a vested interest in this. And so recently, myself and others at my institute have embarked upon a prospective clinical trial studying the use of a particular immunotherapy, checkpoint inhibition, which I can go into in more detail, for patients, pediatric patients in particular, with hepatocellular carcinoma. This clinical trial, as I mentioned, is prospective, studying the use of this drug in patients with both conventional HCC and fibrolamellar carcinoma. And a lot of this trial arose from data we had at our own institution. We had treated a handful of patients, pediatric patients with HCC, with checkpoint inhibition, and found remarkable variation in response. For some patients, we achieved stable disease for an extended period of time, which was in and of itself, a win. For some patients, unfortunately, their disease didn't respond and continued to grow. But for one patient in particular, we achieved a complete remission. That patient was a fibrolamellar patient. So that got us thinking, on the basis of that preliminary data, this is something we should be rigorously studying prospectively to obtain enough evidence to determine whether we should continue to study immunotherapy in this patient population. As I mentioned, pediatrics is rare, and so our goal was to design the clinical trial and open it at a handful of institutions, such that we could more rapidly accrue patients and better understand the utility of this drug in this patient population. The trial is funded by the Cancer Research Institute, which has been extraordinary. I think having the opportunity to obtain support for a pediatric-focused endeavor is remarkable. The trial is currently open and enrolling at Dana-Farber Cancer Institute, i.e. the lead institution, Cincinnati Children's Hospital, the University of California at San Francisco, and will open at Texas Children's. And again, these are all pediatric institutes united to better study the role of this agent in particular in pediatric hepatocellular carcinoma.
So it's really encouraging to hear that there is at least one example of a pediatric fibrolamellar cancer patient showing a very strong response to the drug that you described. Maybe you'd like to tell us a little bit more about what a checkpoint inhibitor is and that approach to immune therapy.
Happy to. So checkpoint inhibitor therapy is an attempt to, as I mentioned, reactivate immune cells to recognize tumors. We know that the key immune cell that we are looking to reactivate, or the key immune cell that has been shown to best fight cancer, is the T cell. It's a type of white cell within the body that helps to fight infection, but also can help fight cancer. The problem in many patients with cancer is that these T cells tend to express on their cell surface a particular protein. That protein is called PD-1. Similarly, tumor cells express a protein called PD-L1. PD-L1 likes to bind to PD-1, and when the two bind together, the T cell gets inactivated. It's like a break. The T cell all of a sudden doesn't know how to function. It thinks the tumor's a friend, and it isn't activated to fight the tumor. The beauty of drugs like checkpoint inhibitors is that they break open that alliance. They interrupt that binding. So, for instance, the drug we're studying, pembrolizumab, binds PD-1. So it binds to the protein on the T cell surface. It keeps it from binding to the tumor surface. And in doing so, it eliminates that break with the goal of reactivating the T cell. Now, the trouble with this particular drug is that it doesn't specifically or purposefully reactivate the T cell. It doesn't tell the T cell, okay, now get the tumor. It just reactivates the T cell in general. But what we've seen from adult data and preliminary data in adult HCC patients is that these T cells, when activated, do meaningfully contribute to fighting tumor cells. They may inflame other parts of the body as a collateral, but the reality is what we've seen in pediatrics in much larger studies is that these agents are unbelievably well tolerated in our pediatric population. So our trial hopes to again validate the safety of these agents, but likewise the efficacy in this particular patient population that, if you haven't gathered already, I'm very, very inspired to learn more about and to really help improve outcomes for.
I can hear the passion you have about immune therapy for liver cancer in children, particularly fibrolamellar. If a patient or family is interested in getting more information about the clinical trial you've described, what would they need to do to get that information, and how would they go about enrolling in the trial?
Of course. So please reach out to me, Dana-Farber. But no, I mean, the clinical trial is available to obtain more information about on clinicaltrials.gov. Again, searching under fibrolamellar carcinoma. You will likewise find my name associated with the trial on clinicaltrials.gov. I'm always willing to speak with patients, families, and providers. I think that is one of the greatest joys of my job, is reaching out to an extended network of people, particularly patients and families. And so even if the trial doesn't wind up being the right option for the particular patient of interest, it still allows us a meaningful opportunity to connect about what other options might be available or make the most sense. I think the other thing about the trial that I'm very passionate about is it will allow us the opportunity to better understand the immune infiltrates of these tumors, to better understand whether we take this even further. We think about even more complex immune therapies guiding the treatment of these patients. And I think we're only as good as our data. We as a community are only as good as the information that we learn rigorously and scientifically. And so my hope is, in better understanding the tumors of patients enrolled on this trial, I can better inform not only my own next initiatives, but those of my colleagues at other institutions, those in the Fibrolamellar Cancer Foundation, those equally as passionate about creating a better space, home, and care angle for these patients.
I'm going to ask you something that many scientists are a little uncomfortable to do, which is to do a little crystal ball gazing. And I wonder if you could give us at least some of your insights into future areas in which progress might be made against fibrolamellar carcinoma, and particular things that are in the reasonably near future likely to move into clinical studies in patients.
That is always a challenging question, you're right. I'm very inspired by the number of avenues of study currently underway. And I think we've touched a bit about immunotherapy. I know many of my colleagues are very engaged in questions surrounding immunotherapy. My colleague, Dr. Mark Yauchman in Hopkins, is working and has been working on a vaccine oriented towards these patients, again, with the idea of utilizing the patient's own immune system and the immune cells embedded within these tumors. I think efforts like that and others, over time, we're going to learn more and more about the immune infiltrates of these tumors. My impression is that the immune system does its job best in the context of minimal disease. And so, because I think the challenge we face in solid tumors is penetrating tumors. They're like fortresses. So I think we can certainly enable the immune system to attack peripheral aspects of the tumor, but sometimes we have difficulty getting further in, infiltrating this fortress. And so I think over time, our abilities to deliver immune therapies may really depend on our delivery mechanisms, better understanding whether we can deliver immune therapies directly into tumors as opposed to systemically, hoping that they can get to the tumor in that way. But there's no doubt in my mind that the avenue of immunotherapy going forward for this disease is going to be tremendous. And I think the other avenue, we talked briefly about the chimeric fusion that's associated with this tumor. That's a conundrum of sorts. I think a lot of people have spent a lot of time and energy focused on why that chimera exists and how to target it. If it's the one thing that's so unique to this tumor over and above others, why one can imagine it's part of the key. So I have no doubt that those efforts, either in parallel or conjunction with immunotherapeutic efforts, will pave the future for this disease. Whether chemotherapy or targeted agents play a role, I think what we know is that combination therapy is always better than single agent therapy. You often have to attack tumors from a multi-pronged, multidimensional approach. And so it's plausible that all of these avenues will in a meaningful way combine, and that there might not be one right path. I don't think there's a one size fits all for this disease, but I'm really inspired by the number of avenues currently under investigation.
When a patient enrolls in a clinical trial that is a form of participation in research towards coming up with future therapies for fibrolamellar cancer or any other disease. In other ways, can patients contribute to research, for example, by helping to donate tissue from surgery or other procedures that can be used for research on the cancer?
Yeah, that's a great question. Yes, I think the answer in short is yes, but I'll explain, of course, my thought process behind that. I keep going back to we're only as good as our data and our ability to better understand the biology of disease. And so many of the current practices in pediatric oncology and adult oncology is really looking on a granular level at tumor tissue. And by that, I mean looking at the genetics, looking at the immune infiltrate, understanding how the tumor grows in a dish, in a mouse, exposing the tumor to various drugs in a dish, in a mouse, or in other models. And the only way we can do that is by collecting the tissue. And I think, and the tissue requires certain processing to do all of these various endeavors. And often we're so we're lucky in the sense that we have access to so many unbelievable resources of study, but we can't do any of these experiments or better understand the tumor without the tissue. So a lot of clinical trials have embedded the option that patients can consent to collect tissue. And by that, I mean, if a patient's undergoing a procedure already, it doesn't usually involve an extra procedure. It's the biopsy in the diagnostic setting, or it's the large surgical resection when the tumor is ready to come out, or it's multiple serial resections or procedures. So much tissue is available after a procedure of that sort, in excess of what's required for diagnosis, that it's a fountain of knowledge kind of waiting to be tapped. So patients and families often have the opportunity to consent to what's called biobanking. It's collection of that tissue in a meaningful way. And by that, I mean the tissue can be frozen for future use. It can be utilized right away to generate a model in a mouse, for instance, upon which we can study multiple different drugs. There are so many endpoints to the collection of tissue, and so much we have left to learn that the only way to do so is to bank tissue or utilize it in real time. And so we're fortunate here in Massachusetts that Mass General Hospital has established a biobank specifically for fibrolamellar carcinoma patients in conjunction with a researcher there. And the opportunity for patients and families to consent when their child or their loved one is already undergoing a procedure really would afford clinicians and researchers an enormous enormous opportunity from which to learn more.
Thanks very much for that answer. And I'll put in a plug that the biobank you described is actually funded by the Fibrolamellar Cancer Foundation. Patients and families who are interested in contributing tissue to the Fibrolamellar Cancer Biobank can get more information on that at the Fibrolamellar Cancer Foundation website or by contacting me. Dr. O'Neill, let me just conclude by thanking you very much for providing so much of your time and information. As a member of the Medical and Scientific Advisory Board of the Fibrolamellar Cancer Foundation, we also thank you for the tremendous input you give us on the direction of our research programs, where we should be funding and things we should be supporting. And the dedication you show to that just matches the dedication you show to your patients and their families. So thank you very much.
Thank you. It's a pleasure. Everything I do with the goal of enhancing outcomes for not only this patient population, but every patient I treat. All the research is motivated by the patients. I am exceptionally fortunate to be in a position where I can do both, care for patients that I love and think deeply about the research in improving outcomes for these patients. So it's a pleasure to be involved. I thank you for the opportunity, and it was a pleasure to be here today.